welcome to the Alfred's Emergency Medicine Journal Club podcast. My name is Eanna, Emergency Medicine Registrar, and I'm joined by Professor Peter Cameron, Academic Director at the Alfred Hospital Emergency and Trauma Centre, and Divya, Consultant in Emergency Medicine. Thanks for your time, guys. So we're just after having our journal club for the month of October, and we covered 4 papers. We jumped from Brazil to Spain to Japan and then back to Spain. So I suppose in times when we can't fly overseas, we might as well live vicariously through Journal Club. So let's get stuck into the first paper.
Paper 1.
So the title of this paper, Direct to Angiography Suite Without Stopping for CT Imaging, a Randomized Controlled Trial. This was a paper which was recently published in JAMA and a study which comes out of Barcelona in Spain. So just a brief description of the study. The main objective, as the title would suggest, was to explore the effect of direct to angiography suite on clinical outcomes among patients with large vessel occlusion stroke in an RCT. This is a single-centre, investigator-initiated prospective study. In terms of population, they included all adults with suspected large vessel occlusion stroke with 6 hours symptom onset. 147 patients were randomised, with 74 entering the intervention group and direct transfer to angiography suite, and 73 into the control group and direct transfer to CT scan. And the primary outcome was functional dependence as measured by distribution in the 7 category modified Rankin scale score at 90 days after stroke is in patients with confirmed large vessel occlusion. So the results, the primary outcome analysis showed an adjusted common odds ratio of improvement of 1 point in the modified Rankin score of 2.2, favouring direct angiography suite. 95% confidence intervals 1.2 to 4.1, and p-value of less than 0.009. And the author's conclusion from this was that direct angiography suite significantly improved functional independence for adults with acute ischemic stroke compared with direct CT for usual imaging protocols. So what do we think, Peter? This seems to be a well-oiled machine to have up in Barcelona for the last 2 years. Should every stroke service aspire towards this?
Well, it's an aspiration. I think it's interesting. I mean, this is obviously a high-volume stroke centre, probably more high volume than most centres in Australia anyway. They had started off with over 2,000 patients, got down to 466, and then actually studied 174. So you're dealing with a small percent, less than 10% of the stroke patients that are actually involved in this study. So that's the first thing I think that's important. The other thing is, as you say, this is a well-oiled machine. The patients took almost 4 hours to get to the hospital, but they were dealt with within an hour, and that's pretty impressive, as they say themselves. Compared with most stroke centres, and then there's this issue of what equipment you have in terms of flat panel CT, availability of angio, and availability of expertise 24/7. So I think it's an interesting study and really challenges us, in terms of what we could aspire to. Whether it's applicable to every stroke centre in the rest of the world, I guess, is the question. The other thing about this study is it was clear that there were some other things going on, and one of them was that as well as improved Rankin scores, there were more patients that actually got clot retrieval in the intervention arm, as in the director's angio suite, than the other group. And this probably results from the fact that they went ahead with the clot retrieval once they're in angio that was virtually 100% versus the traditional way of doing it and going to the radiology suite first. So there's a signal there, but we're dealing with very small numbers in a single centre, and I'd like to see a bit more confirmation going forward before I recommended it for every stroke centre outside of this. But congratulations on the group for doing such an expedited approach to clot retrieval. I'm not sure that we could do it at the Alfred where we work, and certainly we don't have the infrastructure in terms of flat CT within the angio.
Yeah, I found that interesting as well. Like, there's 174 patients were randomized to both groups, and there was 292 excluded. I just found it interesting that in a system with a trial like this in the process, it was still vulnerable to this universal issues of stroke care, and those being the primary admission off-site, lack of pre-notification, angiography not being available. So even in a centre where they were doing this trial, they're still vulnerable to the same stuff that every stroke centre is. Divya, this trial had to be stopped halfway through. Do you think this affects the interpretation of the results?
No, I don't think so. I think it was stopped because of the interim analysis and it showed the benefits. And I think, as Peter said, the limitations were probably from the beginning of the study where only a small number were actually included. And if this is from a large centre that sees strokes frequently, I think it'll be hard to replicate in other centres. Given the interim analysis and the benefits, of course, they would have had to stop it. But it's hard to know with those patients, with the confounding that those patients that went to angiography directly, there's an obvious bias to then continue with clot retrieval. And that's where my problem with the study is.
It's interesting, interim analyses. I think unless there's an extraordinarily strong signal, we shouldn't stop a trial because of interim analysis, because it always leaves you with that empty feeling. It was almost a good study, but we didn't quite get there. Personally, I think they should have gone on with this study to make it a large, because we're dealing with only a small number in each arm. And really to base a whole stroke system on, 80 or 90 patients is problematic in my view. If we'd had 2 or 3 times the numbers, I would be more confident, I guess, in the study. So I'm not sure what their stopping rules were, but as much as possible in these large trials, it's better if you can avoid stopping early.
Paper 2.
So the second paper we covered was the BASICS trial out of Brazil. The clinical question that this paper asked was twofold. Number one, in adult ICU patients, does the use of a balanced crystalloid compared to 0.9% saline reduce 90-day all-cause mortality? And number two, in adult ICU patients, speedy administration of resuscitation fluids, does the slow infusion compared to fast infusion of a fluid bolus reduce 90-day all-cause mortality? So like I said, this trial was conducted in Brazil, 75 ICUs, and the data was collected from May 2017 to March 2020, and would follow up to the October 2020 period. The population studied included any patient admitted to ICU with a need for fluid resuscitation, not expected to be discharged the day after admission, and at least one risk factor for AKI. So 2 interventions were assessed, the use of a balanced crystalloid and giving a slow rate of infusion at 333 mL an hour if fluid boluses were required. Similarly, 2 controls were assessed, the use of 0.9% normal saline and giving a rapid rate of infusion at 999 mL an hour if fluid boluses were required. In terms of results, the sodium chloride versus balanced solution, there was no difference in 90-day mortality, 95% confident intervals 0.9 to 1.05 with a p-value of 0.47. And then the second outcome, rapid versus slow administration of fluid challenges, there's no significant difference in 90-day mortality. 95 confidence intervals of 0.96 to 1.11, p-value of 0.46. The authors concluded then that the use of balanced crystalloid compared to 0.9% normal saline did not reduce 90-day mortality, and the use of slower infusion rates when a fluid bolus is required compared to a faster rate of infusion did not reduce 90-day mortality. So 11,000 patients, 75 ICUs, a third of the trial completed during a pandemic. Divya, are you impressed?
I was quite impressed. I think a large trial, but there seems to be a controversy that doesn't die. We've had a few trials, I think from 2018 since the original ones, and we've come to the same conclusion. But there are some issues with the study. I think it was a well-constructed study and recruited quite well. However, there were some factors that were probably beyond the control of the actual organisers there. Especially, it's difficult when patients receive normal saline before they're recruited in the 24 hours before. It really confounds your results if that's what your test is, saline versus other balanced solutions.
Great. Yeah, the limitations, like, I mean, there was great internal validity, I thought, to the study, but in terms of, like, a lot of your ICU admissions were planned surgical interventions, so that might affect mortality as well. Would the limitation of this study make you uneasy and continue with balanced fluids, Peter?
I thought it was a good study. It's huge. And if you ever try to do a study like this, you'll understand just how huge this is. They got away with it, but I think there's two things, as Divya says. There's what was given to them before they entered the study, but also the types of patients. I mean, about 40%, I think, were surgical, post-surgical, which, in terms of an ED audience, makes it slightly different. But what it does, I think, is reassure me that really to give a couple of litres of normal saline probably makes no difference whether it's balanced salt or saline or whatever. Probably doesn't actually make any difference. But and that's sort of good to know, because I remember having arguments with anaesthetists. They're getting very upset about giving a litre of normal saline in a trauma patient. You say, you've got to be joking, just give them a bit of volume and they'll get rid of it. And this sort of is reassuring that it's probably going to make no difference. But it doesn't tell us that if you give you 5 litres or whatever over 24 hours, it might not make a difference. So I think once you go from sort of an acute volume top-up, 1 or 2 litres, to ongoing maintenance and large volume resuscitation, I think it's a different story. But for the normal initial approach that we'd have in the ED, this is very reassuring to me.
Yeah, in terms of the median volumes of fluid administered were very low. I think there was like 1.5 in the first 24 hours. So again, like, I mean, you're not going to see much difference there. In terms of the background to this study, you've got the SMART and SALTED trials, which show that patients who receive balanced crystalloids had better outcomes than those who received normal saline. And this basics trial had around 4,300 fewer patients than the SMART study. And they only looked at 90-day mortality as their primary outcome. So for me, I wouldn't be throwing out the balanced solutions just yet. In terms of the rate of infusion, if a patient needs fluids, give it to them fast?
I think that's a clinical decision. I mean, I think if you've got an old dear who, has a small intravascular volume and a dodgy heart and poor kidneys, you probably want to titrate judiciously. If you've got a young trauma patient whose blood pressure is 60 and you're trying to keep them alive till they go to theatre, then giving a litre of saline or plasmolite quickly to keep them alive is probably okay. That's a different argument in some ways, but whether you use hypovolemic resuscitation, but let's say it's sepsis. The other thing, there's a little signal in this paper that was quite interesting about the TBIs, which I thought it was sort of, it's just hypothesis generating, but it does make you wonder that the TBI group has been shown with, osmotic solutions and so forth to behave differently. So I think there needs to be a bit more exploration about the best way of managing vascular volume for patients with TBI.
Yeah, it's an interesting hypothesis generating question as well. Divya, does that change your management at the minute in terms of like your management of TBI patients? Would it affect your management?
I think if physiologically it makes sense, and I would be a lot more cautious about giving larger volumes of crystalloid to TBI patients, especially with the previous trials proving some benefit. This study I think really just opens that debate up and for us to be more cautious. I think that's where my practice would be.
Paper 3.
Moving on to the third paper, diagnostic accuracy of lung point of care ultrasound for acute heart failure compared to chest x-ray study among dyspneic older patients in the ED. This paper comes out of Japan and is published in the Journal of Emergency Medicine. So in terms of population, they screened all consecutive patients who were assessed for shortness of breath or cough who were 50 years or older and had suspected diagnosis of acute heart failure or COPD exacerbation. And only patients evaluated with POCUS were included. So in terms of methodology, this was a cohort study with additional health records review between March and September 2017. The reference standard was discharge diagnosis, ED diagnosis with confirmation by another physician, or diagnosis made by health record reviews. The outcome was to determine the classification performance of lung point-of-care ultrasound compared with chest X-ray study to identify acute heart failure in older patients. The results, sensitivity of POCUS was 92.5% and specificity was 85.7% when identifying acute heart failure, which is superior to the 63.6% sensitivity and 92.9% specificity of radiology reading of chest X-ray. And the author's conclusion state that lung point-of-care ultrasound performed by emergency physicians in real clinical setting was highly sensitive and specific in identifying acute heart failure and at higher sensitivity than had chest X-ray study among older patients with suspected acute heart failure or COPD in their ED stay. So there's a few limitations to this study. Peter, what was your take on this?
Yeah, I didn't really like this study much. I think the main issue with this study is is what the gold standard is. And, if the gold standard is what the emergency physicians who did the ultrasound think is the diagnosis, then you're really getting the emergency physicians to basically both do the test and say what the diagnosis is, and then saying the diagnosis is what they said. So it's just not the way you'd want to construct a study. So really, it should have been that the diagnosis was made independently by a separate physician, and the ultrasound was undertaken by a person who came and did the ultrasound, walked away and said, I think it's A, B or C. So I think the way it's constructed was almost bound to give the result that POCUS was good.
Yeah, I think the point was made that there's so many other studies out there which have stronger methodology, which show a benefit of ultrasound. David, does it affect your management at all? What's your current management with POCUS and shortness of breath, dyspnea in patients?
From my experience and in my practice, I think it's useful in a subset of patients where we have a high sort of pre-test probability and then suspicion for heart failure to diagnose a pleural effusion. And occasionally we see something like consolidation that would change our management. But this study doesn't really sort of give me that much confidence in the design. I agree that there's better design studies that point to it, but I think this is probably a bit more biased for POCUS, in my opinion.
I just found that this paper, they initially said that they had 70% of their staff were credentialed in POCUS and only 2% of the patients they screened were included in the study, which doesn't fill you with confidence here. But I suppose focusing in the right hands and getting a ready diagnosis can be very complementary to the overall investigation. So lots of other papers out there confirming that POCUS can be very useful. So we'll leave that one behind.
Paper 4.
So for the last paper, the title of the study was 1 versus 3 week mobilization period for non-operatively treated proximal humeral fractures. This was published in the Journal of Bone and Joint Surgery. And again, we're jumping back to Barcelona in Spain, which is getting a good shout out this week. So the population here is a single centre study. It was conducted between 2015 and 2018 and included all non-operatively treated proximal humeral fractures, where there was a greater than 50% contact between the humeral head and the diaphysis, no glenohumeral dislocation or glenoid fracture, no previous intervention on the shoulder, and included all patients over 18 years of age. The intervention, patients were randomized into two groups. Group 1, the intervention group of 1 week of immobilization, and the control group were immobilized for 3 weeks. The main objective of the study was to determine the differences in pain between proximal humeral fractures that were treated with 1 week immobilization. So overall, 111 patients were enrolled in the final analysis. There was no significant differences found between the two groups when it came to pain, as measured by the visual analog score at any point, be it 1 week, 3 week, 3 months, 6 months, 1 and 2 years. And neither was there any significant difference in the constant score or the simple shoulder test scores between the two groups. Complication rates were also similar. And the author's conclusion are short and long mobilization periods yielded similar results for non-operatively treated proximal humeral fractures, independent of fracture pattern. So Peter, I want to start with yourself. Ask an important question. This is a very vulnerable patient subset who really need the use of their shoulder to carry out the ADLs. Are you comfortable immobilizing patients for 1 week based on this study?
It's an interesting study because they had quite big numbers, for this particular group of patients, and one of the main limitations is which group the orthopaedic surgeons don't operate on, and that would vary considerably even at the Alfred, let alone between the Alfred and various overseas institutions. So I'm not sure about the generalisability between different centres because the patient group, it could be quite different. But even taking that into account, they had over 100 patients, and there didn't seem to be a lot of difference in complications, pain, or anything else. And the sort of rate of non-union, the things that we fear most of all, things like non-union and reoperation were very low, I thought. So in some ways it was sort of reassuring that it probably doesn't matter too much what you do with these people if you decide they're non-operative. And that's probably, to be honest, that's probably been my practice. Because, often these people are frail, elderly, sometimes demented, and often, trying to immobilise them is difficult, and getting them to follow instructions is difficult. So, and obviously you wouldn't want to immobilise them for long periods of time. So again, and what sort of immobilisation they use, there's a number of sort of things that I'd like to tease out, but whichever way it goes, it's sort of reassuring that it probably doesn't make a lot of difference.
Yeah, just one thing that struck out for me, I think all patients got a CT scan of the shoulder as well, which wouldn't necessarily be common practice and would probably give you more of an argument to immobilise them as opposed to going for shoulder intervention. Divya, what do you think? Is this going to change your practice?
I actually liked the study quite a bit. I thought, this was something that was going to be useful. If you look at the mean age, it's sort of 69 to 70-year-olds, and most of them, who need their function and to maintain their independence before that age group that is mainly in the nursing home. So I thought this was really useful, especially a week of immobilisation. I would say we mostly tend to be non-operative from what the orthopaedic colleagues do at the Alfred.
For the public patients.
That's true. So at the Alfred, I would say the majority of them, at least 75%, unless they're professional athletes or so on in that age group especially, would be non-operative anyway. And if there are no differences with the period of immobilisation, I think restoring the function and rehab earlier would be definitely a better outcome. So I think this is really reassuring.
Yeah, I liked it as well. There was no, in a situation where there's no consensus for the optimal management, it is a greenfield site for research. In terms of follow-up, I think this paper just really does highlight the benefit of early follow-up by physio and rehab and an ortho OPD appointment. I don't know, in terms of generalizability, how tightly these patients will be followed up in the community, whether they get like a 3-week or 4-week OPD appointment, by which case the complications could be significant and detrimental to the patient. So tight follow-up probably really does feature here. Any other points?
That's probably the one variant that would be different between, say, the public and the private patients, wouldn't it? You get early follow-up and increased multidisciplinary involvement with rehab.
And more imaging, yeah.
Sometimes the public ones, depends a bit on which hospital you're at, but sometimes the public ones do get more multidisciplinary input. Sometimes in private, they get seen by the surgeon and moved on, sort of thing. So it's quite variable, and there isn't a very structured pathway for a lot of these patients.
And this is keeping in mind that most of these were those minimally displaced fractures, so the outcomes were probably going to be reasonable anyway. Yeah,
I think the complication rate was really, really small. Only one patient had an ORIF in the second group. Okay, well, that's great, guys. Thanks very much for that. So that concludes our Journal Club podcast for the month of October. So we'll be back next month with another podcast. So Peter and Divya, thanks very much for your time.
Thank you.
Thank you. Well done.